Good evening. Welcome to Village Voices. I'm Dorothy Robine, and I'll be filling in for Trudy Peterson this evening. She'll be back in February. She'll be back before then, but you'll see her next here in February. Tonight, we have a particularly timely topic, the Affordable Care Act, and a speaker, Michael Hash, who was in the room where it happened. Before I introduce Michael, though, I want to do a little bit of housekeeping. First, I want to thank Mary Bloodworth and Judy Berman for tech support, and Karen Stuck and Majean Daniels for publicizing tonight's event. We got a terrific response. I also want to briefly mention two upcoming Village Voices talks. On Monday, February 9th, our speaker will be Heidi Applegate, an art historian with an interesting focus on the art and artists who appear in and give rise to certain works of fiction. You've probably seen Heidi featured in those Smithsonian listings of talks that you really want to sign up for, but never quite get around to. For her Village Voices talk, she will analyze the art and architecture in the best-selling novel Rules of Civility by Amor Towles. Heidi has also taught a course on the ethics of art museums. This is very relevant for the Smithsonian in particular, and it's a topic that hopefully she'll address in the Q&A, if not her talk. And then on Monday, March 2nd, we'll hear from Kathleen Friedel, another PhD historian. Kathleen's focus is American history. Kathleen, who was on the faculty at UC Berkeley, Go Bears, has written two award-winning books, The GI Bill, 2009, and Drug Wars in America, which came out in 2014 and was listed by Vox as one of its best books. Her talk in March will draw on her latest book, Liberalism and the Reinvention of the Modern Corporation, which Oxford University Press just published. She looks at how in recent years, corporations have claimed new attributes, think corporate personhood, to shield themselves from regulation. Let's see. Let me just say, I'm going to introduce Michael in a second, but we'll take questions at the end. If you worried about forgetting your question, put it in the chat, and Mary Bloodworth is going to monitor the chat. So now for this evening's talk. When it comes to the Affordable Care Act, which has been much in the news lately, Michael Hash, as I said, was quite literally in the room where it happened. He was the deputy director of the White House Office of Health Reform, which President Obama created in 2009 to carry out his campaign commitment to fix American health care. Congress passed the ACA in 2010 after a very protracted debate. And at that point, Michael moved to the Department of Health and Human Services, where he directed the implementation of the ACA as head of HHS's Office of Health Reform. The debate over the ACA, or Obamacare, never really ended. Michael spoke to Village Voices in 2019 on the impact of the landmark legislation and why it remains so contentious. And tonight he'll talk more about the latest controversy involving the expanded subsidies. Just a couple of notes on Michael. He did his undergraduate degree at Washington and Lee and graduate work in political science at Vanderbilt. He has spent his entire career, from what I can tell, working on healthcare policy as a congressional staffer in the White House and at HHS. He's a longtime resident of Capitol Hill and served on the board of Providence Hospital, and I think on the Capitol Hill Village board as well. Michael, take it away.
Thank you very much for that very generous introduction. I am looking forward to hearing from all of you about your thoughts on this topic as well. But what I really would like to do tonight is take a look at some of the conditions that gave rise to the enactment of the Affordable Care Act, including some of its major original features and some of its continuing threats to its operation. I also want to, of course, talk about the current political debate around the ACA, and in particular the question of the adequacy of tax credits to help make coverage under the ACA more affordable. And then I want to also apologize to those of you who may already be familiar with much of this history, but I did think that it might be useful to provide some context around how we got to where we are now. So if I could have the first slide, please. I think, there it is. As the title slide previously showed, the ACA is like a cat with considerably more than 9 lives. It's had a number of near-death experiences since its enactment in 2010. But I think it may help some to have an understanding of how it was that it came to be, and sort of what are the key origin features that led to the enactment of the law in 2010. As everyone in this call, I'm sure, is aware, universal coverage for healthcare has been a very long sought goal. From the time of the passage of the Social Security legislation in the 1930s, support for including coverage for health benefits, along with cash income, was at the center of those political debates. President Roosevelt advocated that for Social Security to actually include health benefits along with the cash income provisions. President Truman proposed the first real national health coverage program that was based on a universal plan that did not involve any reliance on private health insurance. Quite a departure from previous efforts. In 1965, as again I'm sure you're aware, under the leadership of President Johnson, who was accompanied into office after the election of 64 with very large congressional majorities, he led an effort that resulted in the enactment of the Medicare and Medicaid programs that extended coverage to seniors and to low-income families. Today, Medicare and Medicaid are each covering more than 150 million Americans, representing or spending about $1 trillion a year. After the failure of the proposed Clinton health insurance plan during his first administration, President Clinton supported and Congress passed the Children's Health Insurance Program, otherwise known as CHIP, that covered children in low-income families who were otherwise not eligible to be covered by Medicaid. And there are now about 7 million children currently enrolled in the CHIP program. Next slide. The pressures have been building continuously over the last several decades to address some of the shortcomings that I've identified that resulted in earlier failures. And by 2009, despite all the earlier efforts to extend coverage, pressure was increasing because, in part, of the continuing increase in healthcare costs, and of course, an increase in the number of people uninsured. In 2008, there were about 46 million Americans who did not have any health coverage whatsoever, about 15% of the US population. At the same time, spending on healthcare was about $2.5 trillion, and the average cost of family coverage insurance in 2008 was more than $12,000 a year. So in many cases, those costs were offset in part by contributions by employers. But in some cases, if people were buying coverage on their own, they faced responsibility for paying the entire premium. At the same time, the insurance companies particularly in the individual insurance market, entertained a number of practices that really made it hard to get and or keep coverage. For example, the use of pre-existing conditions as exclusions from coverage or exclusions from benefits, even if you already had coverage, but had gotten the coverage while you had a pre-existing condition. In addition to that limitation, there was a lot of discriminatory pricing based on gender and, of course, based on age. Women and older adults were charged more than others for health insurance premiums. College students who were living at home after graduation were, as soon as they graduated, were dropped from family coverage, causing them to be a group of folks who were particularly uninsured because they had maybe not begun their careers and they were just still living at home. And finally, the value of insurance policies that were often available to people at that time were barely more than 50% of the premiums that were being paid. That is to say, of $100 in premium, less than $50 actually went to benefits and the rest to the insurance companies. So obviously, the product was not a particularly economical or a product of high value for consumers. With the election of President Obama, he of course ran on a health reform platform, and it really his election set the stage for a major investment of Obama's political capital. Obama came into office also with significant Democratic majorities in the House and in the Senate, including some 60 Democrats in the Senate who would be key to any future legislative initiatives because you need in the Senate a filibuster proof majority, which translates into 60 senators rather than a simple majority. Next slide. I'm not going to spend a lot of time on this, but just to highlight some of the key provisions of the ACA, but to also say that in putting it together in 2009, 2010, that process was really a product of collaborative efforts between the administration and Congress. And part of that strategy, or the idea behind that strategy, was to ensure that the final product that was put before the Congress was one that the Congress felt some ownership with because they had participated in the drafting of the legislation. And of course, ownership of this kind of controversial legislation was critical because members would face very significant political pressures tied to votes they would be required to make along the way. While this initial bill was the vehicle for reforming the market practices that I described earlier and for improving coverage for low-income families, it contained for the first time a requirement for everyone to have health coverage meeting minimum standards or face a tax penalty. The individual mandate, as it was known, was the mechanism to ensure universal coverage, and it dramatically expanded the opportunity for people to do so. I should also mention, although it's not the focus of tonight's discussion, that the ACA also included a very dramatic expansion of Medicaid eligibility up to families with incomes of 133% of the federal poverty line. Now, in the ACA, as I mentioned a moment ago, there were a number of key provisions, and I'll just run through them. They're listed here on the slide, but very quickly, a ban on pre-existing condition exclusions, new marketplaces where consumers could comparison shop for plans, premium tax credits to lower the cost for lower income families, a standard essential health benefit package, which included in and outpatient hospital care, mental health care, and substance abuse, prescription drugs, and prevention benefits. And those prevention benefits were required to be offered with no cost sharing on the part of patients. And then finally, the law provided for family coverage to continue for adult children up to age 26, which interestingly turned out to be one of the most popular features of the original law. Next slide. Obviously, since 2010, it's been a rocky journey for the ACA. There have been multiple challenges to all or parts of the law. Republicans in the Congress, for the most part, have continued their united opposition to the law, and they've also supported litigation, specific legislation, and certainly administrative changes that would significantly moderate or roll back the original features of the law. The most significant court challenge to the ACA occurred in 2012 when a case brought the question of whether the law was constitutional and some related provisions as well. The result of the Supreme Court decision in 2012 was a finding that the law was constitutional, that it also supported the idea of an individual mandate being constitutional. But the one thing that it did not agree to in its final decision was a requirement for states to expand their Medicaid programs to that higher level of income I mentioned a few moments ago. So the Medicaid expansion was in fact made optional. And that, of course, affected states' willingness to do it on a voluntary basis. I think the next, could I have the next slide, please? There were a number of administrative changes that I alluded to a moment ago that come under the rubric of administrative discretion, which the law allows Congress, or allows the administration, I should say, quite a bit of discretion to administer the laws that have been passed. And some of the changes that were made by administrative fiat were a number which also undermined, I think, the effectiveness of the earlier original provisions. For example, since 2010, the annual enrollment periods, which were originally for 90 days once a year, were reduced to 45 days. The funding for consumer assistance and navigators to help people and toll-free hotlines were cut by about 90%. Funding for advertising and marketing materials were virtually eliminated, and unqualified short-term health insurance plans were permitted to be renewed pretty much indefinitely, whereas earlier they had been limited to very short periods of 90 days or less. These changes really did threaten the new marketplaces by weakening benefit protections, consumer assistance, and really fragmenting the insurance risk pool. Why is that important? It's because premiums certainly rose as those with keeping coverage under the ACA increasingly became more likely to be those with chronic health conditions that required higher healthcare expenditures. Next slide. Considering all of these changes together, let's take a quick look at what the marketplace looks like today. The affordability of coverage is a growing challenge and a long-term threat to the survival of the ACA. Market premiums today can be easily over $1,000 a month in the individual market for a family of four. During the pandemic years when President Biden's administration was in place, Congress passed a bill which included enhanced premium tax credits in order to make ACA coverage more affordable for families, particularly families with higher incomes than had been recognized under the previous income limits. The so-called enhanced premium tax credits were extended to everyone, regardless of their income in relation to federal poverty, but in a way that required that or allowed any family to not have to spend more than 8% of their income on healthcare premiums, which actually ended up benefiting families considerably above the federal poverty limit of 400%. Those enhanced tax credits were in fact temporary, and as you've obviously been seeing all fall, they expired at the end of last year. And it's clear that without these more generous tax credits, the estimated cost of coverage under the ACA is likely to double, or has likely doubled this year compared to premiums in 2025. There was a recent comparison of the average cost of subsidized premiums at the enhanced premium level. And what it showed was that the cost with the original credits of say, found that a family plan would have been about on average $900 a year, whereas with the enhanced credits, that same plan would be available, or would be, I said that wrong. Let me back up. Without the enhanced credit, it would be about $1,900 a year, but with an enhanced credit, about $900 a year. That's more than 100% increase in just 1 year. And yesterday, you may have seen that the Department of Health and Human Services reported that enrollment in ACA plans this year, as of yesterday, is down by 1.5 million. That represents about 23 million total ACA plan enrollees. And the enrollment period is scheduled to end on the 15th of this month, which is 2 days from now, of course. So higher costs for ACA plans will likely result in more people dropping their coverage. The percent of uninsured Americans also, including not only those in the out of coverage of ACA plans, but all the rest of folks who are dropping coverage for whatever reason are likely to increase the national rate from about 7.5% of Americans uninsured to 10% by the end of this decade, significantly eroding earlier coverage gains. And meanwhile, healthcare costs and the cost of subsidies or the reduction in subsidies are, of course, the primary reason for this erosion of coverage and for destabilizing the ACA marketplaces. Next slide. The debate over extending the premium health tax credits, of course, was responsible for the longest government shutdown in history, 43 days. The stalemate ended when Democrats agreed to an offer from Senate Republicans of a guaranteed vote on extending the enhanced premium subsidies for 3 years. Unfortunately, that vote fell short of the 60 votes needed to pass the Senate. A Republican proposal in the Senate to substitute contributions to health savings accounts instead of to premium credits also failed to pass in the Senate, leaving no proposal having passed as of the end of the year. Last week, as you may have noticed, the House, in fact, did pass a so-called clean bill that included the enhanced premium subsidies extension for 3 years. And 17 of the House Republicans broke ranks with their leadership and voted with all the Democrats to pass this 3-year extension of higher tax credits. Now, this measure, of course, is not expected to pass the Senate, but it could become a vehicle for a compromise around the continuing fight over subsidizing the ACA. A possible compromise that's certainly being talked about would likely include some of the following provisions. First, some extension of the enhanced subsidies, not for 3 years likely, but maybe more likely 2 years. A lower cap on the income of families eligible for tax credits, somewhere below 400% of poverty, which was the original limitation. There's also likely to be at least an option to use tax credits not to purchase coverage, but to make a contribution to a health savings account, a high deductible plan that some may have. There's also talk among Republicans of further limitations on abortion coverage under the ACA standard benefit package. And the Republicans have identified reducing fraud in terms of enrollment and eligibility for tax credits as a high priority for any compromise that they would support. Now, key to all of this is the position of the president. Not surprisingly, maybe, the president has sent some mixed signals. Some have interpreted comments about abortion policy to be a sort of stalking horse for a more moderate approach by Republicans to a compromise. But at the end of the day, it's almost, well, it is impossible for me anyway, certainly to predict the president will come out, although for some time it has appeared that he's been somewhat more sensitive to the political pressures that have arisen with the expiration of those enhanced tax credits at the end of last year. So we will see. But of course, without his support, it's unlikely that any compromise would be agreed to in the Congress. Next slide. Finally, where's the ACA headed in the short and long term? Well, that's of course pretty difficult to discern. There's little doubt that there's broad support for affordable, accessible health coverage, and that will continue to play a prominent role in our political debates going forward. But it's also clear that without generous subsidies and some tighter controls on the growth in healthcare costs, that the number of uninsured will clearly grow. It's estimated that as many as 7 million people will be added to the number of those without ACA coverage by the end of this decade, with ACA enrollment falling from about 24 million people last year to about 17 million. It's also likely that the overall uninsured rate of Americans will likely rise from up to about 10% or 30 million people again over the next 5 to 7 years. Separately, another source of uninsured people are the proposed, or not proposed, the enacted work requirements in the Medicaid program for non-disabled Medicaid eligibility enrollees who are required to work a certain number of hours each month in order to maintain their eligibility. Those work requirements are expected to reduce Medicaid coverage by 4.5 to 5 million people when they become fully effective in 2027. So I can say in conclusion that the most likely important factor in the future of coverage and of the ACA itself really depends on the outcome of the midterm congressional elections that are occurring in November of this year. Those elections will obviously have the potential for changing majorities either in the House or the Senate. And with either House changing hands, it's likely that some of the progress that the ACA has made will continue to be preserved. But it's, of course, way too early to predict what the outcome of those congressional elections will be. I hope this has given you a little bit of not only context for all of this, but also how the current debate fits into the larger discussion of coverage and affordability for healthcare benefits. I appreciate your taking time out to attend tonight's meeting, and I look forward to whatever questions you may have. Thank you.
Thank you very much, Michael. Let me take a look at the chat and see what we've got. We have one question I've seen a 1948 campaign ad for Representative Tom Dewey where he embraced universal coverage. He just argued he could do it better. It was included in the Republican platform, I think.
Well, I have to say I'm not familiar with what Dewey's plan might have been, but I do know that Truman had a plan as a part of his Fair Deal proposal or platform that he ran on in 1948. And that plan did, in fact, involve universal coverage in a public plan without any reliance on private insurance.
Do we have any other questions out there? You can use the raise hand function or just unmute yourself and start speaking.
I can see I've overwhelmed everyone.
Michael, let me ask you a question while we wait for others. You said the key factor is the 2026 midterm elections. I mean, 17 Republicans switch sides to support the House clean extension. So, would an even bigger majority make any difference, or are you thinking more of the Senate where a flip is far less likely?
Yeah, I'm thinking more of the Senate because not only is maybe the change in majority not that likely, but in addition, the idea that Democrats will have 60 seats in the Senate after the November elections is very hard to imagine.
Yeah, yeah,
And again, not to get into the arcana of legislation, but I think now most everybody knows that it's not a case in the Senate of a simple majority vote. It's almost always
right.
has to do with whether you have 60 votes in order to stave off a filibuster and therefore prevent the bill from coming to a vote.
Michael, it's Bruce Brennan.
Yes.
Um, I recall that Obama was looking at two problems to fix: access to insurance and affordability or really cutting down health costs. And the compromise that came out with the ACA was just to address the first. Do you have any thoughts on how one would address the second part?
Well, what I can tell you is the bill that passed the House for the Affordable Care Act in 2009 included a provision for an independent cost review board to, in effect, have some authority to set growth targets for healthcare expenditures. It's a complicated provision, but it was supported by President Obama and by the Democrats in the House, who very strongly felt that, just as you said, that any coverage expansion ought to be accompanied by effective healthcare cost control. However, the Senate, or at least not all 60 members of the Senate at that time, did not agree that such a mechanism was an appropriate thing to include in the final bill. So when the bill passed the Senate, it did not include this particular mechanism for controlling healthcare costs. And it was the Senate bill, in effect, that ended up being the ACA vehicle at the end of the day in March of 2010. So uh, there's a bit of a history about recognizing the need to help to do something about the increase in healthcare costs, but it's always been quite difficult to find politically acceptable constraints that could be put into place that would affect not only public spending for health benefits, but also private sector spending as well.
Um, Mike, this is Judy. I have my hand. I know there's a lot of questions, but I wanted to ask two things. Um, One is about your sense of what was behind the politics, in the sense of um, the insurance companies are certainly doing well. In terms of like the rising costs, we've now got a lot more venture capital, I think, in the health system than we had before. Um, are like what is behind the Republican resistance to the Affordable Care Act, basically, I guess is kind of what I'm asking. Maybe I'll just leave it at that since there's other questions. Like, is there yeah, like I mean, do you have a sense of, like where most of that energy comes from? Oh, before I say anything else, Mike, I just want to say on behalf of, I think, a lot of people, thank you for your work on this. I mean, I know it's been subject to a lot of things, but I hope you're really, you feel good and proud about, what you helped to create.
Thank you. In answer to your question about what is it about the ACA that the Republicans don't like, or I think there are several things here, or several answers to that. One is there is a significant expansion.
Makes you want to speak.
Hello,
Oh.
there's a significant expansion of regulatory authority under the Affordable Care Act, which is, as a general rule, something that is not Republicans are not comfortable with as a role for government. And I think one of the arguments they would make in that regard is the regulation of insurance marketplaces has historically always been at the state level. And the ACA, for the first time, took one aspect of the insurance marketplace, the individual market, and subjected it to national or federal rules and policies. Secondly, I think
That gives them a lot of credit for principles.
well, I also think, and this is obviously something of a partisan comment, but I think that given the salience of healthcare coverage and costs as a national issue for years and years and years, having something that could be represented as dealing with those problems relatively successfully was something that the Republicans did not want to have the Democrats have in their hat or their to their credit. And so I think there were political reasons why they did not want to support this. And then I guess lastly, I would say their view is that, or many Republicans' view, I should say, is that the whole idea of health insurance benefits should be something which is an individual responsibility, including individual employers, and that's how the problem should be solved, and it should not be under the guise of a national health program that's entirely run by the federal government. And they represented the ACA in many cases as that kind of a plan. And you may remember in the summer of 2009, one of the biggest Republican charges against the ACA was that it would create death panels where the federal government would in fact make decisions about who would be covered for what benefits for how long, which gave them the authority to determine who lives and who dies. And it turned out that was a pretty effective argument. I mean, from a rhetorical point of view.
But that's what I mean. Like who's, I guess what I'm asking is like, who's paying them to make these arguments? Because the arguments themselves are, I don't know. That's just that's just my.
Well, I think partly it's employers feel that they should not be told what standard of health coverage they must provide as a minimum for their employees. That's a matter completely up to them and or collective bargaining, but certainly not by government fiat. So I would say the people who are supporting Republicans from the business community come at it from the point of view of these are costs that can be imposed on us that we should determine rather than in compliance with a federal mandate.
And Ellen Murray?
Hi, Ellen.
Muted. Hi, can you hear me now?
I can.
You hear a lot about fraud and abuse. Do you think there is a lot of fraud and abuse in the program? I understand some of it's related to brokers and signing people up that don't exist.
I think there's always some fraud and abuse.
Yeah.
I can't begin to know how widespread it is, but you referred to elements of the way the ACA works that could be the subject of fraud, putting people into plans that they've not chosen, putting people who do not exist into plans qualifying people for tax credits through false income information. So there are a number of aspects of the operation of the ACA, which in the wrong hands could lead to fraudulent activity. And the Republicans have indicated that as a price of doing something that makes those tax credits more affordable, or makes coverage more affordable, that something has to be done to crack down on fraud and abuse. One of their particular proposals is in some geographic areas, ACA plans are available to people for no premium at all, so-called zero premium plans. And they think eligibility for those zero premium plans has been manipulated in such a way that tax credits are flowing to make those zero premiums exist, and they're flowing for under fraudulent information. And so they want to require that there's no ACA plan available for a premium less than $5.
What do you think of that?
Well, what do I think of it? I think some fraud and abuse provisions could be appropriate. What I don't know, and I have to confess complete ignorance, I don't know what the evidence shows. What are the types of fraud, and to what degree, what is the magnitude of each of the various types of fraud? And I think any solution or addressing those problems ought to be based on evidence about this is documented as a serious fraud problem, whereas other aspects there's no evidence. So to me, it should be evidence-based.
Okay, Mike. Two people asked questions that just perfectly dovetail, and I don't think they actually were conspiring. George Hardy said, do you think a compromise can actually be reached in this Congress that can pass both houses? And just followed up 2 minutes later with Cynthia Whittlesey saying, if the Senate won't likely support a 3-year extension, what are the possible Senate proposals and how would they affect the breadth and depth of coverage? Alternatively, what do you think the Senate would propose and accept?
Well, I did try to mention in my remarks some ideas that are being floated as a Republican compromise. Now, I must say I'm not privy to any of these discussions, and my listing of these things is only based on, people I've talked to or things I've read. But the kinds of things that are being talked about, instead of a 3-year extension of those higher tax credits, something like a 2-year extension. At the same time, instead of allowing people who have incomes significantly higher than 400% of the federal poverty to qualify for tax credits because the premiums they're paying exceed a certain percentage of their income, is likely to be something to be cut back. That is to say, the income level go back to 400 or 300% of poverty, and above that, regardless of what you had to pay for premiums, would not qualify you for a tax credit. The third thing that's being talked about is giving people the option, if they otherwise qualify for a tax credit, to deposit that credit into a health savings account, which is attached to a high deductible health plan, or to have it apply toward a premium for an ACA plan. So that's an option the Republicans seem to favor. There's a bit of a debate about the continuing issue of abortion coverage. Currently, abortion services are in fact covered under ACA plans, but individuals pay a separate premium if they want that particular coverage, and that is to ensure that no federal funds are being used to pay for abortions under the ACA. Republicans don't think that limitation is sufficiently tight and would like to prohibit any abortion coverage under the ACA. And then, as I just was talking with Ellen about, the Republicans have a number of fraud provisions they would insist on including in any compromise. Now, do I think this could end up being something that would pass the House and the Senate? I would say yes, but it depends on so many factors. But it's pretty clear that Republicans and Democrats, of course, feel pressure, political pressure, to address the cost of healthcare coverage. And I think it's a possibility that a bill fashioned this way in the Senate could pass with 60 votes, which is the critical threshold. And then if that happened, it'd be very highly likely that the House would also pass that bill as well, given what they just did last week with the vote on a straight 3-year extension. So that's what I think about the possibilities of a compromise, what might be in it, and how likely it is that it would actually pass the Senate.
And I think at least one more question. Adafielek asks, is the USA the only major country without government-sponsored universal coverage?
I can't say I'm completely up to date on that question, but I will say, while the majority of countries that have a health coverage policy, it's usually a government policy. However, there are exceptions like Canada and Australia, where they actually operate what we would call a mixed system, where there is public coverage that's run by the government for certain aspects of healthcare, but also supplemental coverage in the private sector provided by private insurance companies. So the sort of mixed model does exist in some places, but for countries that actually have in place a health coverage plan, it generally is a public plan that covers all the people in that particular country.
Can I ask a little bit more about the politics of it?
Sure.
What's remarkable? Well, one remarkable thing is just the 9 lives, that the debate never ends. Usually when a big bill passes, that's it. This debate has continued um, as if legislation didn't pass. To what degree is that a function of and second, let me just say there's been a change in Republicans. I mean, Republicans are not the same as Republicans were in the late 90s and the early 2000s. I read that 3/4 of all the people taking advantage of the ACA exchanges live in states that Trump carried. So you have some of these positions are odd positions for MAGA to be taking. It made some of your description of the impediments are ideological, but that I associate them with traditional Republicans as opposed to MAGA Republicans. So I'm trying to understand what is driving Republican members in the current MAGA sort of environment, and to what extent special interest groups like insurance companies, pharmacy benefit managers, this big middle thing, that vertically integrated thing that we've created that other countries don't have, to what degree does that drive or determine the outcome?
That's a complicated question, a good one, but a complicated one. I think if you trying to discern the sort of politics of within the Republican Party today, obviously there has been written about widely that there's a core of Republicans, and also elected Republicans, who support the president no matter what on everything. And unless and until he gives a signal in this area for a compromise, I think that group of Republicans, just based on their loyalty to the president and his policies as under MAGA, if you will, that those people are continuing to take the position they're taking because of that. And that's why when the House passed this bill the other day, what it really reflected was Republican members from districts that were relatively close when in terms of the percentage carried by Trump in the 24 election. And those members are the ones who feel the most politically vulnerable for not following the leadership in the House or the leadership of the president, and so therefore those ones have broken ranks. But I think it really comes down to, as far as the politics, it's those Republican members who are feeling constituent pressure um, because of loss of expensive coverage or loss of coverage. Those members are more likely to be looking to be on record for something to address that. That's still not the whole Republican, it's certainly not the so-called MAGA Republicans, at least at this point. Now, again, the president could make this a cause that he wants them all to support in some fashion, and that would make all the difference. With respect to why are we having such high healthcare costs and so forth, is it because of the sort of private sector, particularly venture capital investment in the healthcare system that's grown significantly over the last 10 or 15 years? I would say that obviously has something to do with the rise in healthcare costs. But if you look back over time, healthcare cost increases that we're experiencing now are not radically different than rates of increase in healthcare costs over time. So it's hard to sort of say objectively that because we have more entrepreneurial or capital investment in healthcare, that has amped up the rate of growth in healthcare costs simply because of that. And I think that might be a hard case to, given the history of healthcare cost increases.
I was thinking of that more as a political factor than an economic factor.
Yeah. Oh, yes, yes. Oh, and in terms of influence.
Yeah,
Yeah.
right.
No,
Resistance to change. Yeah.
yeah. But I do think you cannot underestimate, because we've seen it time and time again, the power of the president with respect to a significant core of the Republican Party. And as long as he's either not said or if he opposes some kind of compromise, I think it becomes much more difficult to see that happening. But I do think, as I may have mentioned in passing, that there's some signs that, of course, with the president, one day is not like the day before or the day tomorrow. But I do think there have been some signs that he senses the political risks that are associated with opposition to anything. And I suspect there would be conversations, at least among his advisors, about, how far could they go? What could they do to address on a political level something that looks like they're a constructive party to addressing the problem of high cost of health insurance. How they get there, I don't know.
Any other questions? Anybody we missed?
No, and I think we may have hit time.
We're out of time. Michael, thank you very much. This was
Uh,
really terrific, boy.
Thank you.
Michael.
Thanks so
I
much,
enjoyed-
Michael.
Good
I
to see
enjoyed
you.
being here. Bye-bye.
Thank you,
Bye.
Michael.
Thank you.
Thanks.
Bye, everybody.
Thank you.
February 9th, Heidi Applegate.